Hi friends, let's try to solve this question bank of surgery which is for SLE exam. Now few things before I start this question bank. This is a purely recall based question. So many times the recall is very poor. Second, many times the recall is totally wrong. And many times the one who is writing this question, he totally forgets or totally skips those parts which are very important. So we will try to solve one by one. The second thing, we are going to try to solve it in roughly in three parts. So let's start with the question. The first one is a 65-year-old heavy smoker is coming for a general examination. What is the best screening test for him? Now here the patient is an old male and the second thing is he's a heavy smoker. Now this is a risk factor for many diseases. Here the choices are osteoporosis, colon cancer, abdominal aortic aneurysm. But with this age 65 years and heavy smoker, there is one disease which should come into our mind is abdominal aortic aneurysm. In fact, one of the major risk factor for abdominal aortic aneurysm is smoking. Though smoking is risk factor of many disease, but here smoking is very much associated with abdominal aortic aneurysm. So I would go with abdominal aortic aneurysm. And the screening which is recommended is patients who are more than 65 years of age should at least once be screened for abdominal aortic aneurysm, or patient who are 55-year-old but with a family history of aneurysm should be screened for aneurysm. Coming to the second, male patient came with a scalp open wound after 6 hours assault. What would be the wound management? Now here, this is an old outdated question, nowadays not being asked. The 6-hour rule, it was initially followed many years back, but now it is not being followed. In the past, it was recommended that once the wound is more than 6 hours old, one should not go for primary closure of the wound. But the things have changed. Now it is very clear that whenever we can get a chance, we should close the wound. The second thing regarding this 6 hour, there are few important things regarding 6 hour. If there is any fracture, if there is any reperfusion injury, chances increases after 6 hours. So if there is any vascular anastomosis done, then in those patients there are chances of reperfusion injury. So fasciotomy should also be done. Similarly, if some earlier it was said that a open fracture should not be managed primarily if it is more than 6 hours. Now the rule has changed. For up to 24 hours, even the open fractures can be managed. So whenever the chances we get, you should go for a primary closure. Now the third question is, patient had pancreatitis 6 weeks ago, now complaints of epigastric pain and tenderness. Ultrasound shows mass with thick wall and fluid. WBC highs, what is the diagnosis? So now here we are talking about complication of pancreatitis. One complication of pancreatitis is pseudocyst formation. So pseudocyst formation can be just simply collection of the fluid, which is walled off fluid, and the other thing is sometimes the fluid inside may become infected. So in that case, the diagnosis will be pancreatic abscess. Now here he has written about WBC is high. So if WBC is high, if the patient has pain, then it goes with the diagnosis of pancreatic abscess, and in those cases the management would be drainage. So now let's recall few things about the pseudocyst. Pseudocyst is one of the very common complication after pancreatitis. And what is the management of pseudocyst? The pseudocyst, there is a rule of 6. If the cyst size is more than 6 week, if it is more than 6 centimeter, then only it needs management. Few of the recent management people are saying that it should be 12 week, but in the old books it is 6 week. So 6 centimeter size, more than 6 week, then only we should manage the pseudocyst. So what is the management? The ideal management is internal drainage of the cyst either into the stomach or into the duodenum. So we can go for open cyst gastrostomy or cyst duodenostomy. Sometimes if the cyst is far away from the stomach or duodenum, then sometimes we can go for Roux-en-Y cyst gastrostomy or Roux-en-Y cystostomy. Many sorts of new innovations have been discovered. Like one can go for endoscopic treatment like transgastric or transduodenal endoscopic drainage. Or sometimes if the pseudocyst is communicating with the pancreatic duct, we can also go for ERCP with stenting. That can be done with for pseudocyst. If the pseudocyst becomes infected, that is it goes and forms an abscess, then in those cases external drainage should be done. Now coming to the next question, patient diagnosed with ulcerative colitis 6 years ago, when to be screened for colon cancer. Ulcerative colitis, as we know, it's a disease of the colon and it is a risk factor for the cancer of the colon. The risk of the colon cancer increases if the disease is pancolitis, and whole of the colon is involved. If the inflammation is too much, or if the disease is very severe in intensity, then the risk of the cancer increases. This is one. The second, if the patient has pancolitis, the screening should start after 8 years of start of the pancolitis. If it is only left-sided colitis, then the screening should be done after 12 to 15 years of the start of the disease. Regarding the cancer in ulcerative colitis, it is more poorly differentiated and more aggressive as compared to sporadic colon cancer. Some people develop PSC, that is sclerosing cholangitis, in ulcerative colitis. If some patients develop sclerosing cholangitis with ulcerative colitis disease itself becomes mild, but the chances of cancer becomes more. In a patient of ulcerative colitis, if you find a colonic stricture, it means with almost 100% surety we can say that it is most likely we are dealing with a cancer of the colon. Next question, child presents with hip and groin pain and ultrasound was done to reveal hip joint effusion. He is afebrile. What is the most likely diagnosis? So here 2 to 3 things. The patient is a child. He has a hip joint effusion but without fever. So if the patient does not have fever, we can rule out septic arthritis. If the patient does not have fever, we can rule out osteomyelitis. So this is a common condition found in children, which is known as toxic synovitis. The name is toxic, but most of the time it is a self-limiting disease. Patients, usually a male child, presents with limping and there is an inflammation in one of the hip joints. It usually is a sequelae of some of the viral fever, and it is self-limiting disease. So the answer is toxic synovitis, and the treatment is just painkillers and anti-inflammatory and some rest. Next, WHO published the WHO surgical safety checklist in 2008 in order to increase the safety of patients undergoing surgery. The checklist consists of 3 phases of surgical procedures. So here we are talking about WHO surgical safety checklist. So there are basically 3 important things we need to remember: sign in, time out, and sign out. So when the patient comes inside and we identify the patient, that is known as the sign in. The second is time out. Time out is being done by one of the sister in charges. She will read out everything, and this time out will be done before any surgical intervention is started. And before giving incision, you have to do the time out. Sign in before induction of anesthesia, time out before giving any incision, and sign out is once the procedure is over and all the staffs, before they leave the OR, they have to go for a sign out. So this is a safety checklist. Next question, patient came after 3 days after Roux-en-Y surgery complaining of fever with chill and left shoulder pain. So here the patient is having, it's a post-surgical patient, and patient is having fever with chills and a left shoulder pain. So fever with chills with a left shoulder pain means there is some collection in the left diaphragmatic region, and the patient is having shoulder pain because of the irritation of the diaphragm. So how you're going to confirm the diagnosis? So for all these, to confirm the diagnosis, the best is one should go for a CT with contrast. Even one can go with start with an ultrasound, because ultrasound is a good investigation to tell us about the collection. But if somebody asks for the best investigation, the choice will be CT with contrast. Which of the following is true regarding necrotizing pancreatitis? So here is a question regarding pancreatitis. The choices are increased lipolysis, hypoglycemia, and decreased gluconeogenesis. Now we know that the pancreatitis is basically the main pathophysiology is activation of the enzymes, and it's basically the trypsin is activated, and later on we find that the patient develops proteolysis and lipolysis. So the answer will be lipolysis. Next is trauma patient with extraperitoneal bladder injury. What's next step in the management? So we are talking about the extraperitoneal bladder injury. So bladder injury is of two types. One is extraperitoneal and the other is intraperitoneal. Extraperitoneal is very common. It is found in about 80% of the times, while intraperitoneal is found only in 20% of the times. The mechanism of intraperitoneal in bladder injury is when the bladder is full and somebody has a direct blow on the lower abdomen, then it gives rise to rupture of the bladder into the peritoneal cavity, and the patient may present with peritonitis. Here the management is we have to go for a laparotomy and repair of the bladder and after repair of the bladder we have to put the Foley's catheter for around 2 weeks, and then most of the time the bladder will be repaired. While if the patient has developed extraperitoneal fracture, it is very commonly seen with the fracture of the pelvis, and here urine collects in the layer of pelvic fascia or in the perivesical space. So there is a deep collection, and what we have to do in such cases is, in most of the time we have to just put a Foley's catheter, and this Foley's catheter will be there for 2 weeks, and most of the time there is a healing. There is one sign associated with extraperitoneal bladder rupture that is known as teardrop sign. So if we do a cystogram, the contrast will leak into the perivesical space, and it will take a shape of the tear. That is known as teardrop sign. Next question is, patient was extubated after thyroid surgery and immediately developed shortness of breath and respiratory distress. Examination reveals that both vocal cords are in a semi-closed position. So both the vocal cords are in a semi-closed position. It means the patient has developed bilateral recurrent laryngeal nerve injury. So if somebody has bilateral recurrent laryngeal nerve injury, the major issue is the patient develops respiratory embarrassment, and here how you are going to secure the airway. So the best is you have to re-intubate the patient as soon as possible, and later on you manage the nerve injury. So the answer will be re-intubate the patient. Which of the following indicates compensated shock? So the shock occurs in various stages, and there is a classification like grade 1, 2, 3, 4 depending on the blood loss. So if it is up to 15% of the blood loss, it is grade 1. If it is 15 to 30%, it is grade 2. If it is 30 to 40%, grade 3, and if it is more than 40% of the blood loss, it is grade 4. So in the initial 1 and 2 stages, the shock is said to be compensated, that is blood pressure does not drop, and the patient has, in the first grade, the patient has just mild anxiety, urine output is good, more than 30 ml per hour, pulse rate is less than 100, while in grade 2 the pulse rate is more than 100, urine a bit decreased, 20 to 30 ml per hour, and but still the blood pressure is normal. So in these patients blood pressure is normal, then we say it is a compensated shock. But in grade 3 and grade 4 the blood pressure decreases, and we say that the patient is having decompensated blood pressure shock. So here the choices are anuria develops in the grade 4, confusion is in grade 3 and grade 4, while mild anxiety will be there in grade 1 and grade 2. Hypotension develops in grade 3 and grade 4. Pale peripheries, yes, the patient can have pale peripheries in a case of compensated shock, so the answer will be pale peripheries. Next question, pelvic fracture with injury to the membranous part of urethra, blood seen in the external meatus, what is the most appropriate action? Now here we are talking about the pelvic fracture and its relation to the urethra. So the urethra can be divided into two parts. The urethra can be divided into two parts, that is the anterior urethra and the posterior urethra. Anterior urethra is bulbous urethra and the penile urethra, while posterior urethra is prostatic and the membranous urethra. Overall, the most common site of injury is the bulbous urethra, and in a case of pelvic fracture, the most common site of urethra injury is membranous urethra. The first part is the prostatic urethra, which is covered by the prostate, and the second part is the membranous urethra. At the junction of the prostatic and the membranous urethra, usually this part ruptures. So in a case of pelvic fracture, the most common site is membranous urethra is ruptured. So what happens is, once the membranous urethra ruptures, the prostate is going high, and so what we will find is the patient is having retention of urine, blood at the meatus, and high lying prostate. When we do a rectal examination, we will find that the prostate is very high, and we will find a pelvic hematoma. So this is the characteristic of membranous urethra injury. While if somebody is having bulbous bulbous urethra injury, which is more common. It is basically direct hit on the perineal region. Then the patient develops bulbous urethra injury. So how to differentiate between bulbous urethra injury and the membranous urethra injury? In the bulbous urethra injury, the urine extravasation takes place in the perineal region, or the hematoma is there in the perineal region. While in a case of membranous urethra injury, the collection or hematoma is deep in the pelvis, while in a case of bulbous urethra injury, the patient will have retention of urine, blood of the meatus. Prostate will be normal if we do a rectal examination, and there will be a perineal hematoma. This perineal hematoma may be just limited to the penis, or may be limited up to the scrotum or anterior wall of the thigh, depending on whether Buck's fascia is ruptured or not. So coming to the next question. So membranous part of urethra. So if you come across patient having membranous part of the urethra, so what will be the management? The management is we have to go for a suprapubic catheter, that is known as SPC. We are not supposed to put a Foley's catheter in these patients. We are supposed to put a suprapubic catheter, and later on we can plan for management of the rupture of the urethra. Next, lymph node swelling with clear lymphatic fluid in the swelling, what to do? Now here most likely the question is incomplete, it's a poor recall. Most likely it's a small child which is having a swelling, clear lymphatic fluid and a swelling, and on aspiration we find a lymph. So this is most likely a cystic hygroma. So few words about cystic hygroma. This is found in posterior triangle of the neck. It is brilliantly transformation positive, and it is sequestration of the lymph in the. So that is why on aspiration we find the lymph, and it is soft and compressible. Whenever the child cries, the swelling increases in size. So what is the management? The management is basically a combination of surgery and sclerotherapy. So because it is a benign condition, so we are not. So the choice is we go for surgery as well as sclerotherapy. Old patient comes with subdural hematoma with signs of lateralization. Image revealed 13 mm shifting. GCS is 7/15. So the GCS is very poor. And the patient is intubated and resuscitated. What to do next? So if a patient who is having a subdural hematoma, who is having such a low GCS, and there is midline shift, so what is the best thing to be done is, in such a conditions where the patient is deteriorating, where the patient is having midline shift, in such patients we should always go for a craniotomy to decompress. Next is patient involved in road traffic accident with multiple mandibular fracture with severe bleeding, unconscious, no vitals mentioned. How would you manage his airway? So as per the ABCDE protocol of the ATLS, the first thing is airway management. So the best airway management in a patient who is having trauma and who is unconscious is orotracheal intubation. But here the patient is having multiple mandibular fracture. So in these patients it would be difficult to do a orotracheal intubation. So in such patients we have to go for surgical airway management. In patients, if we are in urgent need of surgical airway management, the best is we should go for a cricothyroidotomy. And if the time allows, we can go for tracheostomy. So but in emergency situation, cricothyroidotomy is the answer. Next is long case of medullary thyroid cancer. What is the appropriate management? Known case. So it's asking about the medullary cancer thyroid. What is the management? So few things about the medullary cancer of the thyroid. It is one of the types of the cancer which is non-follicular in origin. It arises from the C cells, that is known as from the C cells which secretes calcitonin, and this is a neural crest origin. C cell is the origin of neural crest. Now medullary cancer of thyroid occurs in two settings. It can be sporadic most of the time, and so sporadic is usually occurring in about 6th decade, and the other is associated with familial or syndromic, that is associated with either men type 2A or men type 2B. Now there is how to differentiate between sporadic and familial. Sporadic is usually unilateral, while the familial or syndromic is usually bilateral, multifocal, more aggressive, and often found at the younger age group. Medullary carcinoma thyroid is associated with RET proto-oncogene mutation. So if in a family, if we find that the patient is having RET proto-oncogene mutation, it is the thyroidectomy in a child is justified. So one should go for a prophylactic thyroidectomy if somebody in a family, if we are finding red proto-oncogene mutation, because the medullary cancer thyroid develops in younger age in these groups, and it is a very aggressive disease. So how to diagnose medullary thyroid cancer? The diagnosis is by FNAC. We will find amyloid stroma in this FNAC. And what will be the management? The management will always be total thyroidectomy with central lymph node dissection, because it often metastasizes to the lymph nodes. We have to go for a central lymph node dissection. And other than that, if the size of the medullary cancer thyroid is more, we have to also go for the prophylactic lymph node dissection on the side of the tumor. If we find the patient is if we find the patient is having lymph nodes on one side, we should also go for modified radical lymph node dissection of that side. But central lymph node dissection has to be always done in such patients. Next question. 55-year-old patient was diagnosed with autoimmune thyroiditis with a history of progressive enlargement of right lobe of the thyroid. FNA report malignant cell. Which of the following is most likely type of the thyroid malignancy? So here the patient is having autoimmune thyroiditis. So one of them autoimmune thyroiditis is Hashimoto's disease, and patient is having progressive enlargement of the right lobe of the thyroid. Whenever we come across a patient who is having a goiter and which is suddenly increasing in size, we should think about one disease, that is lymphoma, because the lymphoma is very rapidly increasing in size and it is very commonly seen in Hashimoto's disease. So how to confirm the diagnosis? Either by FNAC or by core biopsy. And what is the treatment? Treatment is mainly chemotherapy. Patient with hemorrhoids that is reduced on its own. What is the grade? So we know that there are 4 grades of the hemorrhoids, and first will never come out, it will only cause bleeding. Second comes out but reduces spontaneously. Third is we have to reduce manually, and the fourth is it's always outside, that is irreducible. So here the answer is obviously the second degree hemorrhoid. What is the management of hemorrhoid? Now depending on the type of on the grade, the management. Initial management is the patient should avoid constipation. Then if it is bleeding, one can go for injection sclerotherapy. The other option is one can go for banding of the hemorrhoid, and the open surgery is done if it is grade 3 or grade 4. Next question. Lactating women present with right breast pain for 6 days on examination, hot tender swelling lateral to the right areola. Patient start to take fluoxetine. Ultrasound shows cystic lesion, thickened content. What is the next management? Now here there is a patient who is having most likely there is a cystic, most likely the patient is having basically breast pain along with tender swelling. So the most likely the patient is having breast abscess. Now what is the management of abscess? Basically the management of abscess is we have to drain. Recent advance in the management of the breast abscess is that once we can do is we can go for a trial of aspiration under the coverage of the antibiotics. So this is also a this is a treatment nowadays being followed. If it fails, then we can go for frankly incision and drainage. Now if the patient has picture like this, we have to keep in mind that there is one malignancy also presents like this, and that malignancy is known as inflammatory breast cancer. We have to always keep in mind a young patient, young female who is having pain in the breast, redness, inflammatory breast cancer can also present with this type. But here patient is having lactating female, so the most likely in the lactating female, if the patient presents like this, it's going in the direction of mastitis and breast abscess. 68-year-old man has been advised to undergo surgical treatment for a reducible inguinal hernia. What is the treatment? So basically it is a question asking about management of the hernia. Management of the hernia, there are 3 types of management. One is herniotomy, that is just open the sac and put it inside without putting any mesh. That is known as herniotomy. It is done in kids. The other is herniography, that is the tissue repair like Schuldi's or the Bassani's. So it's nowadays not done too much, but it is still one of the types of the treatment. The third type, which is the most common treatment nowadays being done, is the hernioplasty, that is mesh repair of the hernia, and more specifically Lichtenstein tension free repair of the hernia. So here the answer will be open mesh repair. Diabetic patient with pseudo hyperepithelializing in situ, what you should do? So pseudo hyperepithelializing in situ is a diagnosis is a disease which mimics squamous cell carcinoma. So if on on biopsy we are getting pseudo hyperepithelializing, that means it is not a cancer. So if it is not a cancer, it is a totally purely benign disease, and we have to manage the diabetic foot as such. We don't need to go for amputation. We have to take care of the ulcer. So basically we are not going to go for a repeat biopsy. We are going to just manage the diabetic foot. We don't know exactly what is the status of the diabetic foot in this patient. Next question. Patient with hepatic benign tumor, diagnosis hemangioma, decided to be managed conservatively, but we should advise the patient to. Now, there are again a recall question. There are a few things that hemangioma, as we know, it is the most common benign tumor of the liver, and most of the time no treatment is needed. So it's not like we have decided no treatment is needed in a patient of hemangioma, because hemangioma is the most common benign tumor of the liver. It is most of the time it is found either in the right lobe or the left lobe. Most of the time it is less than 5 centimeter in the size. If it is more than 5 centimeter in the size, it is known as giant hemangioma, and sometimes it needs treatment. And what are the other types of benign liver tumor? The other types of benign liver tumor, just for the recall, is one is the liver cell adenoma and the other is the focal nodular hyperplasia. Only treatment is needed in liver cell adenoma, because liver cell adenoma sometimes converts into malignancy. One. Second, sometimes it ruptures, especially in the females while during the pregnancy. So liver cell adenoma is the only one which needs treatment. Focal nodular hyperplasia does not need any treatment. Hemangioma usually does not need any treatment, except in a condition which is known as Kasabek-Merritt syndrome, where there is consumptive coagulopathy and the patient has decreased platelet count. In such conditions, the treatment is required. Or sometimes in children, because this hemangioma is very common, sometimes these children, they develop congestive heart failure. In those patients, treatment is required. Otherwise, hemangioma does not need any treatment. If we have to go for one choice, I would go for avoid contact, sport, and trauma, because hemangioma is a tumor of the blood. It's basically ectasia of the blood. So if it is a giant one, yes, it can rupture, but it's theoretically. Otherwise, there is no need to take any precaution as such. Yeah, if I have to go for one choice, I would go for avoid contact, sport, and trauma. Next question. 50-year-old male patient, alcoholic with abdominal pain and palpable gallbladder, weight loss, scenario suggestive malignancy, liver enzymes acceptable except for significantly high alkaline phosphatase. What is the diagnosis? So here what you're finding is the patient is an old male who is having palpable gallbladder, weight loss, and so here the examiner wants to ask about something known as Corvaird's law. What is Corvaird's law? Corvaird's law is in a patient of obstructive jaundice. Again, this question is incomplete. Patient must have obstructive jaundice. In a patient of obstructive jaundice, if we come across a palpable gallbladder, it is most likely due to a malignancy. And which malignancy? There are basically 4 malignancy, which is known as periampullary tumor. This periampullary tumor is not one cancer, it is a collection of 4 cancers. What are the 4 different cancers? Most common is cancer head of pancreas. The next is distal cholangiocarcinoma. Then we have a duodenal adenocarcinoma, or we have ampullary carcinoma. So we have 4 cancers which collectively is known as periampullary cancer. And what is the presentation? The presentation is painless progressive obstructive jaundice with a palpable gallbladder. This is Corvaird's law. And what is the management? The management is, if the disease is early stage, then we have to go for pancreaticoduodenectomy, that is known as the Whipple's surgery. Next question. Patient post foot crush injury with heavy object come with excruting pain and pale cool limb. Best next step. Now here the patient is having a crush injury. With crush injury, there is a chance of development of compartment syndrome. What is compartment syndrome? Compartment syndrome is a condition where the pressure inside the compartment is so high that the venous return is impaired. That leads to compartment pressure. If we don't treat the compartment pressure in time, what will happen? Ultimately, the patient may lose the limb. So what are the clinical features? The clinical feature is excruting pain. The most important thing is the pain out of, even by the passive stretch of the muscle, the patient develops pain. And the other clinical features develops, but it is later on, that like pulselessness, paresthesia, pale limb, this develops later on. So here this is most likely a patient having compartment syndrome, and what we have to do is we have to go for a fasciotomy. An ideal fasciotomy in a case of leg is 4 compartment fasciotomy. Next is old male patient did total thyroidectomy. He developed swelling in the neck, with inspiratory stridor and shortness of breath in the ward, how you will manage. Now here we are talking about complication of total thyroidectomy. Any complication of thyroid post surgical complication where there is a collection, patient has it's not given the patient in the question, but most likely the examiner wants to ask, there is a collection, patient has developed a swelling. Yeah, the patient has, sorry, there is written in the question, patient has developed swelling. So this is most likely a hematoma. So this hematoma, because it's a neck, it is pressing the airway. So what we have to do is we have to evacuate. We have to open the sutures and evacuate the blood and shift the patient to OR for definitive management of the bleeding vessel. Next is, patient had a stab wound in the chest, came with weak thread pulses, raised JVP, equal bilateral air entry in both lungs. What is the diagnosis? So here the patient is having a chest trauma, but already we know that bilateral equal air entry is equal. So if the patient has equal bilateral air entry, it means we rule out pneumothorax, because in case of tension pneumothorax as well as cardiac tamponade, we will find that the JVP will be high and the patient, but in a case of tension pneumothorax, the air entry will not be equal. So this is a clear case of cardiac tamponade, because we are having Beck's triad. All the three. What is the Beck's triad? The heart sound is muffled, the patient has increased JVP, and the patient has decreased blood pressure. So we are finding all these three things here. So this is a cardiac cardiac tamponade. And what we have to do is, what is the management of cardiac tamponade? Cardiac tamponade can be managed by aspiration, and if it is very severe, sometimes we have to go for removal of the fluid for the surgery. Next is, patient with history of sleeve bypass with history of leak, present with severe pain and hypertension. Next step, and hypotension. So this sleeve gastrectomy is a type of bariatric surgery, and it is one of the fastest growing bariatric surgery, very commonly done at all the places. One of the major complication of sleeve is leak, the leak from the stomach. This leak can be early as well as late. In both the conditions, if the patient develops leak, and most of the time you have one has to go for a laparotomy, and here the patient is unstable, so we have to go for laparotomy and repair the leak. Next is, case with history of blood coming from ear and perforation tympanic membrane. What is the cause? Okay, so we are talking about the hemotympanum. Now hemotympanum is one condition which is very commonly seen in basilar fracture, base of the skull. If we are having a base of the skull fracture, we may find hemotympanum. What is basilar fracture? Most common bone involved in the basilar fracture is temporal bone. The characteristic feature are hemotympanum, that is blood behind the tympanic membrane. The patient can develop CSF, which may be leaking from the ear or nose. The patient can develop battle sign, that is the retroauricular, that is on the mastoid. We can find ecchymosis, or we can have a raccoon eyes, that is the orbital ecchymosis. All these are features of the basilar skull fracture. So the answer will be basal skull fracture. Next is, male victim of gunshot to thigh, pale and unconscious. BP is 90/60, 130. Next step. Now here again we have to follow the ABCD of the trauma management. The patient is unconscious. Unconscious patients, the first thing we have to take care of is the airway management. So we will go for intubation of this patient. Next question is, patient with anal fissure not responding to drug, what procedure is suitable for this condition? Now, regarding anal fissure, what is the most common site? The most common location is midline posterior. And what is the treatment? The treatment is, first we have to go for a sitz bath, lactulose, and chemical sphincterotomy. Chemical sphincterotomy in the drugs like calcium channel blocker like nifedipine or nitroglycerin. Here the drugs have failed. When the drugs have failed, then we have to go for surgical management. And what is the surgical management? The surgical management is lateral internal sphincterotomy. We are not supposed to go for posterior anal sphincterotomy. It has always to be lateral internal sphincterotomy. Now picture of two huge echinococcus hydrated cysts, but size was not mentioned, asking what is the most appropriate initial step. Okay, so we're talking about the echinococcal, that is the echinococcal cyst hydrated disease. A few words about the hydrated disease. It is caused by Echinococcus granulosus. The definitive host is dog. The intermediate host is sheep. Man is an accidental host. So when the man is affected, it is an accidental case, and so where it goes, the cyst is basically formed in the liver. Most common site is liver. Others can go to the lungs and the other side, and we find the cyst. The cyst consists of three parts, three things. One is pericyst. Pericyst is a host structure. So sometimes this question is asked. Pericyst is a part of. So pericyst is a part of host. Then we have ectocyst and endocyst, which is a part of the part of the cystic disease. Most of the time it is solitary. And the diagnosis will be confirmed by ultrasound. In ultrasound, what we will find, maybe we may find hydrated sand. We may find daughter cyst, which is having a rosette appearance. We may find an amorphous mass, or we may find a calcified structure. So in this condition, we can diagnose that it is having hydrated cyst. What is the management? The management is, initially we have to always give the albendazole. Initially we have to give albendazole maybe up to 3 cycles, and then we have to take the patient for definitive management. Definitive management is surgery. The most common surgery being performed nowadays is known as PAIR, PAIR. That is, we have to puncture the cyst. We have to puncture the cyst, then aspirate the content, then instill the scolicidal agents, and then re-aspirate. This is known as the PAIR technique. There are many scolicidal agents. Most commonly is hypertonic saline. And once we have done this, after doing the surgery, we have to again go for give few cycles of albendazole. So basically we have to always start with the albendazole. There are other surgeries also being done, like some people may go for directly pericystectomy, removal of the whole of the cyst. Coming to the next question, best way to assess the patient spine after road traffic accident. If we want to just assess the spine, in the initial after road traffic accident, the CT scan is enough. If the question specifically asks spinal cord, then we have to go for an MRI. But spine, best is we have to go for a CT scan. And spinal cord, for the best investigation for spinal cord is MRI. Patient fell on orchestrated hand, pain is and at anatomical sniff box. Which bone fracture is it? Okay, so the anatomical sniff box, this is the location of the scaphoid bone, and scaphoid bone is the most common carpal bone fracture. And one very important complication we have to keep in mind is avascular necrosis of proximal half, not distal half. Avascular necrosis of the proximal half takes place sometime in a case of scaphoid fracture. Now, a 45-year with a history of pancreatitis, then recurrent vomiting, upper GI bleeding. After resuscitation, what should be done? Splenomegaly, normal portal. He became stable after injection of physical therapy. Which of the following best way to management? Now, the patient is having a pancreatitis. One of the complications of pancreatitis is splenic vein thrombosis. So, if the patient develops splenic vein thrombosis, one complication can develop is patient can develop varices in the stomach, and this varices may bleed. This condition is also known as left-sided hypertension. So patient may present with upper GI bleeding because of this varices in the stomach. And what is the treatment? Treatment is splenectomy. So here the answer will be splenectomy. Next patient, cirrhotic patient complicated, came with portal hypertension, came with upper GI bleeding. So patient is having patient is a known case of cirrhosis, and patient is coming with upper GI bleeding due to varices. What would be to give her resuscitation? So now here we will start with the ABC of the management, okay? And then regarding the drugs, terlipressin is an established drug nowadays. Earlier we used to give the octreotide and vasopressin, etc. But now terlipressin is the initial drug to be given. And once we start with the terlipressin, because we already know that the patient is having cirrhosis, and then we have to take the patient for endoscopy as soon as possible. And what is the aim of the endoscopy? The aim of the endoscopy is to localize from where the blood is coming, second, and to take care of the varices. The best way to take care of the varices is we should go for a banding. So banding is the best way to control the bleeding. Now next, 26-year-old male came to with epigastric pain relieved by eating and worsening by fasting. So a pain in the epigastric region relieved by eating and worsened by fasting goes in favor of duodenal ulcer. Okay, which of the following next step is the first investigation? In the first investigation, the choices are abdominal ultrasound, endoscopy, urea breath test, blood antigen. So here we have to first confirm the diagnosis. How to confirm diagnosis? We will go for an upper GI endoscopy, not the urea breath test as marked here. So we will go for an upper GI endoscopy to confirm the diagnosis, whether it is a duodenal ulcer. And so here the other thing is, when we are doing when we are doing the upper GI endoscopy, okay, we can also go for this. We can also go for some test to know about the status of the H. pylori. So if we are doing an endoscopy, the best is we can go for rapid urease test from the tissue. If we are not going for an endoscopy, if we want to diagnose a case of H. pylori, we can go for serology. And once the treatment of H. pylori is given, and to know whether the H. pylori is eradicated or not, the test which should be done is urea breath test. So again, I will revise. Okay, so H. pylori, as we know that H. pylori is associated with 90% of duodenal ulcer and about 75% of the gastric ulcers, and H. pylori is associated with cancer and the other things. So if we want to rule out or confirm the diagnosis of H. pylori, what we can do is, if we are doing an endoscopy, we can at the same time take out a tissue and we can do a rapid urease test. If you're not doing an endoscopy, if you still want to know the status of the H. pylori, we can go for a serology test from the blood. And once we have treated the patient for H. pylori, after that we can go for a urea breath test. Now next question. Patient after motor vehicle accident at ER, vitally stable in examination, showed left hypochondrium tenderness and ecchymosis. What is the most appropriate test? Okay, now this question is not clear. One, it is not showing what is the status of the patient. But any patient who is having an abdominal trauma, the first thing we can do is, after going for an ABCD, we can go for an fast, because fast is done on the bedside in the emergency room. If the patient is stable, then we can send further the patient for CT scan. Which type of CT scan? It is contrast enhanced CT scan. But the first test to be done is the fast, and if the patient is stable, we have to go send for CT scan. If the patient is unstable, we give a challenge of the fluid. Even after giving the fluid challenge, if patient is unstable, then in those cases we can go for a laparotomy after fast if the patient is unstable. So it all depends on whether the patient is stable or not. Next, 76-year-old male with reducible inguinal hernia and moderate pain. What is the treatment? Now here, this is a tricky question in the sense that what examiner wants to ask exactly cannot be said. If the patient is having pain, it means the patient is developing complication. If the patient is developing complication, we should go for a surgery. So basically, either a bad recall or what, I don't know. But if the patient is developing pain, one must go for surgery in a hernia, even if the patient age is 76, because if the complication develops, the chances of mortality are high. So I would go for, if the patient has pain, I would go for like mesh repair. If the patient is asymptomatic, yes. If the patient is asymptomatic, if it is a reducible inguinal hernia, so most likely it will not develop any complication, and then just we can leave the patient like this. So it all depends on whether the hernia is reducible or not. If the hernia is developing any complication, we have to go for surgery. If the hernia is not developing any complication, we can just because considering his age, we can just keep the patient like this. Next is case suspected to have renal stone. What is the best diagnostic tool? The renal stone or the ureteric stone, the best is, because they have high calcium and they are radio opaque, the best investigation to diagnose is non-contrast CT scan of the KUB region. So NCCT is the answer, CT scan is the answer. Now regarding renal stone, most common renal stone is calcium oxalate stone. This is the most common. What is staghorn calculus? Staghorn calculus is a special name being given to triple phosphate stones. Triple phosphate like magnesium, ammonium, calcium, phosphate. So triple phosphate stones, and it is found specifically in the alkaline urine. There are some of the stones which are found in the acidic urine, like uric acid stone. One stone is cystine stone is very different type of stones, because it is found in cystinuria, and the stone initial color is pink or yellow, and it changes its colors to green once it is exposed to air. So that is the characteristic of cystine stone. Coming to the next question, about a lady, known case of gallstones for 15 years. So a patient having long standing gallstone presented with abdominal pain and fatigue. There was air in the biliary system. What is the diagnosis? So basically, the question is incomplete. Usually, the examiner wants to ask about one of the complications of the gallstone. Long-term gallstone. In long-term gallstone, there is one complication where the gallstone slowly erodes into the bowel. So it erodes into the duodenum and it goes into the small bowel. So what happens is basically patient develops intestinal obstruction. So it is not fatigue, it is colicky pain. So patient develops colicky pain and the patient has air in the biliary system, which is a very characteristic air in the biliary system. So basically there is a communication between gallbladder and stone fistulizes from the gallbladder to the duodenum and then from the duodenum to jejunum, jejunum to the ileum. So patient develops intestinal obstruction. It is not ileus, it is mechanical intestinal obstruction. And what is the management? Management is of any mechanical intestinal obstruction is surgery. So we have to go for surgery, we have to go for laparotomy and remove the stone from the bowel. Regarding the gallbladder, most of the people say that we have to go for cholecystectomy later on. So first is we have to go for a laparotomy. So the answer is gallstone ileus. Gallstone ileus is a misnomer. It is a mechanical type of intestinal obstruction. 65-year-old female with asymptomatic femoral hernia. Okay, what is the most appropriate management? Now, femoral hernia is one of the hernias with highest chances of complication. It is found more commonly in females. It is more found in females who have already multiple children, and usually it is a disease of old age. And most of the time, femoral hernia patient even does not know that she has a femoral hernia, and patient presents with obstruction. So because the chances of obstruction are very high, femoral hernias are always managed by surgery. So what is the surgery? This basically femoral hernia, it is occurring in the femoral canal. So superiorly we have iliopubic tract, inferiorly we have Cooper ligament, laterally we have femoral vein, and medially we have lacunar ligament. So what surgery is done? The surgery is done either without mesh or with mesh, but the main concept of the surgery is the superior and the inferior border, superior, that iliopubic tract, and the inferior Cooper ligament, they have to be approximated. So what surgery we do? We have to reduce the content, and then iliopubic tract has to be approximated with Cooper ligament, either by sutures or by mesh. Next question, 45-year-old male patient underwent appendectomy after signs and signs of appendicitis. Histopathology report, tip of the appendix, carcinoma. What is the appropriate management? Now here regarding the sometimes appendicular cancer presents as appendicitis. So what is the management of that? Now it depends on how it is presenting. If during the surgery we are finding that there is a tumor, if we are finding a tumor, so if the tumor is more than 2 centimeter, directly we have to go for a right hemicolectomy. If the tumor is more than 2 centimeter, if the tumor is less than 2 centimeter, we have to look whether it is at the base or it is the tip. If the tumor is less than 2 centimeter, it's only the tip without any lymph node involvement, we can go directly for appendectomy. But if the base of the appendix is involved, again we have to go for a right hemicolectomy. If the tumor is, if the patient is having a perforated appendix with spillage of mucinous, that is mucinous neoplasm of the appendix, in those cases we have to go for an appendectomy, we have to go for a peritoneal lavage, and then patient may be considered for chemotherapy later on. If in the post-op patient we did an appendectomy, and in the post-operative biopsy report we come to know that the patient is having a cancer. So now here how you are going to manage. If it turns out to be adenocarcinoma, we have to go for right hemicolectomy. So if it is adenocarcinoma, right hemicolectomy. If it is a carcinoid tumor, because carcinoid tumor is very commonly seen in appendix. If it is carcinoid tumor, it again depends on the size. If it is more than 2 centimeter, go for right hemicolectomy. 1 to 2 centimeter, now you have to check for whether there is a lymphovascular invasion. If there is a lymph node involvement, vascular invasion present in the biopsy report, we have to again go for right hemicolectomy. And if it is less than 1 centimeter, we can just observe the patient. So in a post-op patient, if it is less than 1 centimeter carcinoid, we have to just observe the patient. Now next is about a fistula with discharge located posterior to anal sphincter. What is your management? So here the patient, they are asking about the fistula surgery. Any fistula, either it can be low type or high type, depending on whether the internal opening is above the anorectal ring or below the below the anorectal ring. The best and the easiest surgery for the low fistula is fistulotomy with a very low rate of complication. So fistulotomy is the basically treatment of choice. Now if we're talking about the fistula, let's just revise the Goodsall's rule. What is Goodsall's rule? Goodsall's rule is, if and if we find an external opening anterior, so the internal opening will be just radial to it, just in a straight line, while if we find a external opening in posterior to this midline of the anal canal, the internal opening will be in the posterior midline. So this helps us to understand the tract of the of the ring of the fistula tract. And there is an exception. The exception is if the anteriorly it is more than 3 centimeter, then the Goodsall rule fails, and the internal opening will be again in the posterior midline. What is the most common in fistula? The most common fistula is intersphincteric type of fistula. Now coming to the next question. Patient, a known case of ulcerative colitis, did MRCP and showed intra and extrahepatic duct strictures. What is the diagnosis? So here the ulcerative colitis patient is having intra, extra and extrahepatic duct strictures, multiple strictures like musba. This condition is known as primary sclerosing cholangitis. Primary sclerosing cholangitis is associated with ulcerative colitis. There are some extra-intestinal manifestations of ulcerative colitis like ankylosing spondylitis, erythema nodosum, pyoderma gangrenosum, and arthritis. All of these resolves once the colectomy has been done for ulcerative colitis. Because what is the management of ulcerative colitis? The ultimate management of ulcerative colitis is we have to go for proctocolectomy with ideal pouch and anastomosis. So once you do this surgery, these extra intestinal manifestations disappear. But primary sclerosing cholangitis is one extra intestinal complication presentation which does not resolve with surgery. Even if you do a surgery, primary sclerosing cholangitis will persist. And how primary sclerosing cholangitis presents as? It may be very mild. It may present just with elevated enzymes, or patient may present with obstructive jaundice. And the very important thing about ulcerative colitis and PSC is ulcerative colitis is mild in such conditions, but the risk of cancer is more. Yani ulcerative colitis with PSC, risk of cancer is more as compared to simple ulcerative colitis. Next, patient has blunt trauma. Patient is stable, fast showed intraperitoneal fluid. Next step. Now here the patient is having blunt trauma abdomen. Fast is already done. There is intraperitoneal fluid, but the patient is stable. So once the patient is stable, what we have to do is we have to go for a contrast enhanced CT scan to know exactly what are the other organs which has been injured by this trauma. Next, truck driver with severely painful gluteal swelling management. Now here there are two very important tips. One is truck driver and the other is painful gluteal swelling. So there is one disease which is known as Jeep disease. Basically it is found in those people who are driving for long hours, like truck drivers, and this disease is known as pilonidal sinus. In the pilonidal sinus is a condition which is usually found in hairy people, which is usually found in those people who are continuously driving, like those who are driving jeep or truck. Here there is a swelling in the natal cleft over coccyx, and the main reason is supposed to be the hair goes inside and then it forms the cyst. And what is the management? Management is always surgical, but there are high chances of recurrence. So we have to go for removal of that cyst, and we have to remove all the hairs from inside. If the patient sometimes develop infection of this pilonidal sinus, then in those conditions we have to go for incision and drainage. So like here in this condition, patient is having severe painful. So if the patient is having severe pain, it means it is an infected pilonidal sinus, and the choice will be we have to go for surgery, that is incision and drainage. Next, patient has fever, high WBC count, lactate is 3, mean arterial pressure was 65 and was maintained on vasopressin. So the basically patient is having fever, patient is having high WBC count, and patient is in shock. Patient is being given vasopressin and the lactate is 3. What is this condition? So it is a straightforward question. In a patient, this is a type of septic shock because the patient is having high WBC count, so there is a there is some source of infection. Whenever there is a lactate more than 2, it's again going in favor of septic shock. So it's a straight away septic shock. Case of multiple gastrointestinal ulcer, gastroduodenal ulcer with upper GI bleed. What lab test to do? Now here the patient, again the question is incomplete, but what they want to ask is basically patient is having multiple ulcers. So one of the, if we come across patient who is having multiple ulcers, we should think about one disease that is known as gastinoma, also known as Zollinger-Ellison syndrome. So what happens is the gastrin is high, and how much high? For if we want to go for one level, if we are finding more than 1000 unit gastrin, that is confirmatory. But most of the time the gastrin is above 200 units, above 200 units in a fasting state. Or if we do a secretin stimulation test, we will find that the gastrin increases more than 200 units. Then we can say that this patient is having gastrinoma. Few things about the gastrinoma is it is the most common functional malignant pancreatic endocrine tumor. It is a malignant tumor. Most common site is duodenum. There is one triangle that is known as Passaro triangle or gastrinoma triangle. Most of the 90% of the tumors will be found here. Though this triangle is bounded by cystic duct CBD junction, then duodenum second part and duodenum third part, and pancreatic body and pancreatic neck junction. So this forms a triangle. 90% of the times there will be the location of the gastrinoma will be in this triangle. How to exactly locate for exact location of this tumor, we can go for we can go for octride scintigraphy. And what is the presentation of these patients? Gastrinoma, the most common presentation is patient is having pain in abdomen because of multiple ulcers. So any ulcer in multiple ulcers or ulcer in not common sites like ulcer in jejunum, we should suspect gastrinoma. And the patient also has diarrhea. What is the treatment? Treatment is always surgical. Next question is, so 25-year-old breastfeeding women with breast pain, tenderness and swelling, but there is no fluctuation. What is the management? So because there is no fluctuation, the patient is having only breast pain and tenderness. So it is going in the favor of mastitis. If it is just pain and tenderness, it goes in the favor of mastitis. But if there is a fluctuation test positive and then it goes in the favor of abscess. So in a case of mastitis, only antibiotics. Once it is an abscess, we have to go for either aspiration under antibiotic or open drainage. 51-year-old female, medically and surgically free with no family history of colon cancer. Which colon cancer screening test is appropriate for her? So colon cancer screening ideally is done like at some places it is 45 years, some places it is 50 years, but we can go for 10 years full colonoscopy. That is one option. Second option is we can go for 5 years sigmoidoscopy, and third option is we can go for annual fecal occult blood test. It is said that cancer of the colon always has some amount of blood coming, and if fecal occult blood test is positive, then we can go for colonoscopy or sigmoidoscopy. So annual fecal occult blood is okay. Next is 50-year-old female, 50-year presented to ER with sudden left lower chest pain and epigastric pain after forceful vomiting. So here the condition is after forceful vomiting, the patient has sudden chest pain. On examination, there is a decreased breath sound in the left lower chest. What is the most likely concern? No, because here it is a forceful vomiting, and one condition after forceful vomiting, if somebody develops chest pain and there is a decreased air entry, it is going in the favor of esophageal perforation, and this condition is known as the Burhaff syndrome. But this is more commonly seen in male, more commonly seen in alcoholics. There is a triad known as Meckler's triad. The Meckler's triad is patient is having chest pain, patient is having vomiting, forceful vomiting, and followed by chest pain, severe chest pain, and patient is have cervical subcutaneous emphysema. This is known as Meckler's triad, and it's a very strongly goes in the favor of perforation of the esophagus. And if we do a chest X-ray, we will find pleural effusion or hydropneumothorax. Now coming to the next question, patient is obese and tried to lose weight with diet and exercise but failed. His BMI is 43 and his HbA1 is 8.5. So the patient is diabetic and his BMI is 43. So what is the most appropriate advice? The most appropriate advice for somebody having BMI 43 is patient is morbid obesity, and we can go for bariatric surgery. So what is morbid obesity? So let us look at the definition of morbid obesity. It is more than 100 pound more than 100 pound of ideal weight, one. Second, twice the ideal weight, or BMI is 40. BMI is the most consistent. BMI is being followed. So BMI is better one, 40. These patients are known as morbidly obese. And what is the criteria of surgery? The criteria of surgery, if somebody is having BMI 40, he can go for bariatric surgery. Or if somebody is having BMI 35, more than 35, with comorbidities like diabetes or joint pain, he can go for surgery. What are the types of bariatric surgery? Just for revision, there are two types of surgery. One is restrictive and the other is malabsorptive, and the third is mixed of both. So like restrictively, in the restrictive surgery, the most commonly being performed is the sleeve gastrectomy. The other is the laparoscopic adjustable gastric band. And the third, which is not done nowadays, vertical banded gastroplasty. In the other criteria is mainly restrictive with some malabsorptive component like Roux-en-Y gastric bypass. And the third criteria is mainly malabsorptive with some amount of restriction like biliopancreatic diversion and duodenal switch. Now coming to the next question, case of right flank pain, hematuria, painful micturition, okay. So basically the question they want to ask about, the patient is having right flank pain with hematuria, and the first thing which comes into our mind is the renal stone or the ureteric stone. So we have to go for a CT scan without contrast. Next, this patient came after limb trauma with severe pain and paresthesia between his toes, and it was pale. So the patient is having paresthesia and the patient is having pale. The patient is having severe pain. X-ray shows fracture. Intercompartmental pressure was 35 mg. Okay, intercompartmental pressure 35, more than 30 mg is that it is a very high compartment pressure, and we have to go for a fasciotomy. So here we have to go for a fasciotomy because the patient has developed compartment pressure, acute compartment pressure. Next is post appendectomy, 2 cm carcinoid found on the tip of the appendix. What is your management? As we discussed in the earlier question, if on the biopsy it is more than 2 cm at the tip of, whether it is at the tip or whatever, we have to go for a right hemicolectomy. Next is post left thyroid lobectomy, female complains severe shortness of breath. It's again a repeated question. The patient is having post thyroid hematoma, and you have to we have to open the suture and evacuate the blood. Next is case about pleural effusion on chest tube. After a while there is blood in the water, hemorrhagic pleural effusion. How to manage? Now again the question is not very clear. It's an incomplete question. I think the question examiner wants to ask about hemothorax. In the criteria for surgery for hemothorax is if the patient has 1500 ml blood at the time of insertion of the tube, then we have to go for thoracotomy. Or if it is 200 ml every hour for 3 hours, then we have to go for thoracotomy. Otherwise, tube thoracostomy is enough. Next is 65-year-old male known case of atrial fibrillation presented with severe abdominal pain on examination. There was abdominal tenderness. Lab showed WBC is high. Okay, so basically here the patient is having atrial fibrillation, and after atrial fibrillation, we know that one of the complications of atrial fibrillation is few thrombus goes from heart and goes here and there. So what has happened is patient developing severe abdominal pain. So this is a case of mesenteric vascular ischemia. Mesenteric vascular ischemia. What has happened is one of the thrombus which has started from the heart has gone into the one of the vessels of mesentery, like superior mesenteric artery, and it is causing the severe pain. So what is mesenteric vascular ischemia? What are the types? It can be divided into two types. It can be acute and it can be chronic. In chronic, we don't need to do any surgery. This condition is also known as bowel angina. Whenever patient eats food, the patient develops pain in the abdomen. That can be managed conservatively. And in the acute case, it's an emergency. The causes of the acute mesenteric vascular ischemia are emboli lodging into the vessels, like in this case, and it is responsible for around 50% of the cases of acute mesenteric vascular ischemia. It is basically the atrial fibrillation which is responsible for 50% of the cases of mesenteric vascular ischemia. The others are like there is a thrombus formation, about 15%. Then there are venous occlusion, and there are about 20% of the cases there are non-occlusive cases, that is known as because of the spasm. So acute case, how to manage? Basically, what is the presentation? The presentation is pain out of proportion. That is the most important thing. The books write that the patient has a lot of signs, but there is no, the patient will have a lot of symptoms, but no sign. That is, when we press the abdomen, we don't find tenderness, we don't find guarding, but the patient is in severe pain, then we should suspect mesenteric vascular ischemia. The signs develop when already the damage has been done, like when the patient develops peritonitis or localized peritonitis, then the patient develops guarding and rigidity. And what is the management? The management is we have to go for urgent urgent surgery and removal of the embolus, and that is okay. Coming to the next question. Next question is a 12-year-old boy injured with supracondylar fracture and distal radial pulse is absent. Which of the following is the appropriate next step? Now here it is a complicated case of supracondylar fracture because radial pulse is absent. Because supracondylar fracture is often associated with brachial artery injury. So if there is a brachial artery injury and the radial pulse is absent, what should ideally be done? Ideally, we have to explore the region and brachial artery injury has to be dealt with. But now again the question is incomplete. Nowadays it is being said that if the patient has the hands are warm and it is not pale, we can go for conservative management. Otherwise we should always explore the brachial artery. Next, football player during a pass developed severe right iliac fossa pain and swelling, irreducible. So patient developed iliac fossa pain after the patient took a pass, that is after. So what is the management? Here the most likely the patient is having hematoma, that is hematoma in the rectus sheath hematoma. So what is the management of the rectus sheath hematoma? It is basically the conservative management. Okay, most of the time it is the conservative management, and it is basically it is due to epigastric artery rupture. Okay. So now we are going to close this here. Okay, we will continue in the next. Thank you. If there is any mistake, please let me know. Thank you very much.